Good morning, everyone, and welcome to our Monday Night IBD video brunch, reviewing the medical management of short bowel syndrome. This series is supported by an educational grant from Takeda. I'm Dr. Aline Charabaty, the founder of Monday Night IBD and the clinical director of the IBD Center at Johns Hopkins School of Medicine at Sibley Memorial Hospital in Washington, D.C. It is my pleasure to welcome two of my fantastic colleagues and friends, Dr. Subramanian. She's a medical director of the Intestinal Rehab and Transplantation Center at Georgetown Hospital in Washington, D.C. Suki, welcome.
Thank you.
And Dr. Valeria Cohran, medical director of Intestinal Rehab and Transplant at Lurie Children's Hospital in Chicago. Valerie, welcome today.
Thank you.
Well, thank you both for being with us. Today, we're going to focus mainly on the management of short bowel syndrome in adult patients with Dr. Subramanian, but we're very excited to have Dr. Cohran with us because I think the bulk of the experience in how to manage short bowel syndrome really reside with the pediatric gastroenterologist. So we're very happy to have her here and share her expertise and her input. So today we'll review what is short bowel syndrome, how do we define it, what are our treatment goals when we're managing a patient with short bowel syndrome, what are the dietary and fluid management requirements in this disorder, in this syndrome, and what are the pharmacological agents that are available to us for our patient with short bowel syndrome. So let's start with how do we define short bowel syndrome and what is intestinal failure and what are the key symptoms in these disorders. Suki, can you help us with that?
So short bowel syndrome results from the physical loss and functional deficiency of the small intestine such that there is an inability or insufficient capacity to digest and absorb macronutrients, micronutrients, fluid and electrolytes, to the extent that a person often requires some degree of parenteral support. Now, intestinal length at baseline varies. It can vary from 275 to 850 centimeters. This is the length of bowel from the duodenojejunal flexure. The surgeons will often comment about the length from the ligament atreides, from the serosal aspect of the bowel, but we say 275 to 850 centimeters. That's a wide variation in length of bowel. It's important to realize that length is not the sole arbiter of outcomes in short bowel syndrome. So it's a physical loss of bowel that results in this functional deficiency. And it's important to recognize that the remnant length of bowel after a series of resections that may occur from trauma or surgical resections, medical illnesses, but it's the length of residual bowel that is important. And it's the combination of this remnant length of bowel that we often recognize as less than 180 to 200 centimeters, in addition to a constellation of symptoms. And the clinical hallmarks of short bowel syndrome include diarrhea, dehydration, fluid and electrolyte derangement, and importantly, malnutrition. So it's this deficit in the length of bowel in conjunction with this cluster of clinical symptoms.
Thank you, Suki. So living with SBS is not easy. There are a lot of GI symptoms and like you said, patients are at high risk of dehydration and malnutrition. Valerie, what other complication can occur in patients living with SBS?
So in addition to having intestinal failure associated liver disease, line infections or bacterial infections, you can also have thrombosis of these different vessels. So as a result of that, you could actually lose access to provide the necessary TPN that the patients are receiving. You can have injury to your kidney. These patients sometimes receive large amounts of fluid. They receive a large amount of antibiotics, depending on if they have fever. So these kinds of episodes can result in having kidney injury. And the patients are also at risk for kidney stones. So there are a variety of different diseases that can occur, or complications rather. Some are more serious than others. Cholelithiasis, so you can develop gallstones as a result of that. So there are a number of different complications with long-term TPN.
Thank you both. And in terms of keeping in mind the GI symptoms and the complication from malabsorption and the complication from parenteral nutrition, what should be our treatment goals when we are caring for a patient with short bowel syndrome? Suki?
the work of digestion involves a liter of saliva, 2 to 3 liters from the stomach, 1 to 2 liters from the pancreatic biliary secretions. And all of this fluid, that fluid egress into the lumen of the bowel, accomplishes this work of digestion. And the majority of it is reclaimed in the small bowel and colon. So in normal anatomy, an individual only loses about 1/10 of a liter of fluid. And in short bowel syndrome, depending on what that final anatomy is, patients can lose enormous amounts of fluid, 8 or 9 liters a day at times. And this can be difficult to discern when they're eating and drinking. So I think one of the early goals is to get the patient out of a state of crisis, get traction on the volume of the output they're having, because when they have these losses, you are having to replete these with additional parenteral support and electrolytes. So it's really important in the early stages to get traction on the output and try to work to introduce medications and diet to mitigate these losses.
Suki, in that context of having malabsorption and dehydration, what are the diet consideration in patients with short bowel syndrome? What are the what should we recommend to maybe increase or avoid? How do we manage diet and nutrition in patients with SBS?
So one of the main goals in intestinal rehabilitation is to ensure that the patients with short bowel syndrome are adopting a diet that is compatible with, the recommendations that we think will promote adaptation. And the enteral nutrition is critical to achieve that goal. And really, in the long-term trajectory, we're trying to achieve enteral autonomy. In the early phases, I find that sometimes it's the oral intake can stimulate excessive secretions. The patients have high output, and it's very difficult to figure out how much of their losses are related to their intake versus their intestinal secretions. So in the early phases, I will sometimes keep the NPO, keep the patient's NPO in order to try to quantify what their actual net losses are. And then that in conjunction with measuring their 24-hour urine volume as a surrogate and a valid metric of intestinal absorption. And so these things are also done and have been done in our studies, our interventional studies, as suitable metrics of absorption. And these are things I think many of us do in actual practice. But I think in the early phases, it may be important to keep the patient's NPO in order to establish and get a sense of what their baseline is, and then to be able to understand what their parenteral support needs are. After that, we gradually introduce diet. I think oral rehydration solution is a critical component of the nutrition and the fluids that they ingest. You want this optimal osmolality, the fluids that they're ingesting, to, again, decrease fluid shifts and their losses. Diet is also really important, but I think it's critical to either work with a dietitian or, I would encourage people not to be inhibited by the lack of a dietitian. I think you have to start with the patient, understand what they're eating and what portions of the intestine they've lost. Often I will do 24-hour fecal fat collection to understand if they have an issue with fat malabsorption and guide them appropriately. We will often encourage patients to incorporate complex carbohydrates, and these will include resistant starches that can, if a patient has a colon incontinuity with their small bowel, the introduction of complex carbohydrates can be very advantageous due to the colonic fermentation of these nutrients that are otherwise unabsorbed. So that's a critical component of dietary interventions. And fat restriction can actually sometimes be necessary. In the Western diet, a dietary restriction less than 50 grams per day is perceived as unpalatable. But sometimes the fat malabsorption can drive a lot of their losses.
Thank you, Suki. Valerie, Suki was describing the enormous amount of fluid and electrolyte that are lost in a patient with short bowel syndrome. How do we replace that fluid and those electrolyte loss? And is there any electrolyte or fluid replacement solution that's favored over others? Is it oral? Is it IV? What should we be using in patients with SBS?
So I really think it depends on the patient, especially early on after their initial perhaps resection or insult. Those patients are not necessarily going to tolerate large amounts of replacements through their intestine, whether they're taking it by mouth, where frequently my patients are taking it through a G tube. So a lot of the patients actually may receive it earlier on IV. And over time, as a patient is hopefully adapting, the goal is for them to either take it through their tube or take it by mouth. For children, we probably use more Pedialyte and that type of replacement, but I know there are other oral replacement solutions that are available that are probably used a bit more in the adult population. But again, the main purpose of these solutions is to provide extra electrolytes. So if you're losing a lot of fluid from your stomach, from a jejunostomy or an ileostomy, you can have tremendous amount of sodium losses. So that has to be replaced. So it either needs to be replaced in the TPN or you need to replace it enterally. Early on, it's going to have to be replaced IV, but the goal is over time, you may be able to supplement them more and more in their intestine as you try to taper down on their TPN. The sodium losses can be very tremendous. With the stool losses, they can have bicarb, that's also lost, potassium. So frequent electrolyte measurements is very necessary early on in order to be able to determine the fluid and electrolyte status of those patients.
So Valeria, I want to continue with you. We talked about diet, nutrition, replacement, fluid replacement, electrolyte replacement, parenteral nutrition. Beyond that, what are the medical therapies that are available to us when we are managing short bowel syndrome?
So in addition to loperamide, Lomotil is also used probably more commonly in the adult populations, codeine, and these drugs sometimes need to be increased in order to make sure that they're absorbed properly. So you may use them at the higher dosages that may be what you're using for a patient who may have a little diarrhea as an outpatient. And so it's very important to titrate those dosages up if needed in order to see an effect, in order to be able to slow the transit, because the slower the transit is and perhaps the increased absorption, there's less nutrition or IV fluids or TPN that actually needs to be replaced. Clonidine is also very helpful for these patients, especially those patients who may have a stoma. It's a transdermal patch, and so it can be helpful in slowing down intestinal transit. Again, you have to look for side effects and titrate that patch up depending on how the patient's responding. Antibiotics are also very helpful. These patients are at risk for bacterial overgrowth, so there are a variety of different antibiotics that may be used in order to treat that. And so antibiotics that may be directed more towards anaerobic organisms or gram positives or gram negatives, depending on the patient's history. So it's very important to know your patient's history and know which one may be better targeted. Also, especially after surgery, patients are at high risk for hypersecretion, and they can hypersecrete acid. So the use of antacids, including proton pump inhibitors or antihistamine receptors, are also very important.
Thank you, Valerie. So what I'm hearing now, which is kind of reassuring for somebody who doesn't have a focus on short bowel syndrome, is that many of the medical therapy tools that we have are available to all of us, right? The anti-diarrhea, and make sure that we're optimizing the dose. We're not using just the smaller dose that we typically use in somebody who had a little bit of diarrhea. So optimizing the dose, the anti-secretory, the PPIs, the antibiotic for bacterial overgrowth. So these are tools that we're all comfortable using and should be available to us. So that is reassuring for the general GI community. How about neurotherapy coming up specific for short bowel syndrome?
So in 2019, teduglutide is a GLP-2 analog that was approved in pediatrics. And so this drug has actually been shown to be beneficial with decreasing the amount of fluid that patients needs at the dose of 0.05 milligrams per kilogram per day. In that study, 69% of the patients had 20% or greater decrease in their fluid volume over the course of the 24-week study. Patients were able to reduce the number of hours that they were receiving their TPN, and also they were able to reduce the number of days. It was reduced by 1 day. So that makes a large difference with regard to quality of life for these patients, and the ability for them to enhance adaptation.
Thank you. Thank you, Valerie. How about Suki? How about in the adult population? What kind of experience we have with teduglutide?
I see the GLP-2 analogs as kind of disease modifying, and they have really changed the way we are able to approach this disease and impact patients. So, GLP-2, as you all may know, is an endogenous hormone that we all make, right? It derives from the L cells in the small intestine. We think distal ileum and colon, and it is released and peaks shortly after meal ingestion. So as nutrients percolate down, the release is triggered, and then it exerts its effect, which are pleiotropic on the intestine. It increases the transporters, the sodium glucose cotransport, increases blood flow, encourages persistence of the intestinal villi to enhance absorption, decreases apoptosis. So through all these different effects, it leads to a net improvement in intestinal absorption of nutrients and fluid, electrolytes, all these things. And our endogenous hormone has quick onset, quick offset, and teduglutide has a single amino acid substitution that confers resistance to dipeptidyl peptidase and breakdown. So this leads to increased pharmacological exposure of this drug. So there is a persistent and potentially downstream effect that is everlasting. And so, this has led to kind of significant and meaningful changes in absorption. In the adult population, the steps 1 and 2 trial were done to assess efficacy and safety of this drug. And in the steps 1 trial, patients were, they went through a period of optimization and then were randomized to either placebo or to teduglutide and followed forward over time. So the patients underwent this intensive period of optimization. Urine outputs were measured. They adhered to a drinking menu that was predetermined and then followed over time. And after 6 months, well, first let me say that the primary endpoint was achieving at least, so greater than or equal to a 20% reduction in baseline parenteral support per week. And at 6 months, what they found is that as compared to placebo, patients who received teduglutide achieved a 2-fold greater likelihood of achieving this 20% or greater reduction in their parenteral support volume. And that difference was of clinical significance.
So Valerie and Suki, if I hear you correctly both, it seemed that teduglutide is changing how we manage patients with short bowel syndrome by increasing the patient time away from the IV pole, from being restricted in terms of their activity and having to be hooked to an IV and get rehydration and get their TPN. And I think that's a very important element in restoring a quality of life. So I think this is very important in the way we look at the therapy and we look at the numbers, that these are very significant numbers, but how does this translate to the patient quality of life? It's you're buying more quality of life, you're buying more time free from getting your TPN, your IV fluid, and hopefully that can also translate in decreasing in terms of complication related to TPN and having an IV and getting IV fluids. Every drug has some potential side effects that we need to monitor. So if I have a patient on teduglutide, what are the things I should monitor? What would the patient can expect in terms of potential side effects? Suki, can you help us with that?
With respect to treatment emergent adverse events, I think about 20% of patients had adverse events that were primarily GI in origin, so abdominal bloating, changes in their stoma. A lot of these are treatment effect in a way, and there's a period of acclimation and adaptation. I think it's really important to convey the findings from these studies and real life experience to the patients in order to manage expectations. And a very important thing to discuss with patients is the risk of this trophic factor promoting the acceleration of neoplasia. So it's important that a screening colonoscopy is done within 6 months of starting teduglutide. and at intervals thereafter after initiating treatment for adequate colorectal cancer surveillance. And that is true for patients who have a colon in continuity and in those who have an excluded remnant colon or a Hartmann pouch.
So Valeria and Suki, we talked a lot about the science behind how do we approach therapies in patients with short bowel syndrome, anywhere from anti-diarrhea to rehydration to nutrition to diduclotide. I was wondering if you can share with us how you've seen, the addition of diduclotide in terms of our toolbox affecting patients' life and quality of life. Valeria, maybe we can start with you.
So when I think about patients who've been placed on teduglutide, a lot of these children are on TPN for maybe 12, 14, 16, 18 hours. And the use of this drug has been helpful in decreasing the volume and also the hours that the patients are receiving their TPN. By being able to decrease the volume and sometimes even the days that they're receiving the TPN, it allows them to improve their quality of life and improves the quality of life for the caregiver. And the child is more able to participate and to do things like other children are able to do.
Suki, how about in the adult population? What have you seen? What are the things that you feel have impacted patients' lives with the addition of a drug like teduglutide?
Yeah, so, I have innumerable patients with short bowel syndrome who struggle with a variety of symptoms, that accompany this disease. And one of the biggest burdens of this disease is the high output, high ileostomy output, the high volume of parenteral support dependence, whether it's high ileostomy output or diarrhea. Patients will say, this is inhibiting from activity perspective, from travel. They're kind of tethered to their parenteral support and medical needs. This is a time-intensive and labor-intensive disease, and the patients have to be actively engaged and continuously participating. And so I think the GLP-2 analogs, as they promote and enhance intestinal absorption, have really been life-altering in helping to promote thickening of the intestinal succus, enhancing absorption, and allowing patients some freedom from that parenteral dependence, allowing patients the ability to travel, to return to work, and support themselves, maintain jobs, engage in social activities, regain intimacy with their partners. All of these things, are significantly impact patients' lives. And we have seen all facets of this disease favorably impacted by this hormonal therapy. So in steps 1 and 2, the primary clinical endpoint was achieving at least or greater than or equal to a 20% reduction in parenteral support, because there is some consensus that that degree of reduction is clinically meaningful for both the judicious allocation of resources and also from a patient perspective. What this means is that if a patient is on 5 days of TPN, 20% reduction may mean that they have 1 day off per week of TPN, and that's felt to be meaningful. It enables the patients to be able to engage in activities and perform, fulfill their obligations. But you have to keep in mind that approximately 30% of patients at 30 months achieved enteral autonomy. And the real world experience varies. These were kind of the targets and the endpoints in these initial studies. But this is not necessarily just a few hours off of TPN. Over time, there is continued adaptation. This is a medication that's used chronically over time, and results can vary from patient to patient. But this is effective in some patients in promoting and achieving enteral autonomy and full weaning from parenteral support.
Thank you so much, both of you, Dr. Cohran, Dr. Subramanian, for sharing your expertise and your experience in managing patients with short bowel syndrome, a disease that can be really devastating, both physically and emotionally for the patients and their family and friends and caregivers. So really appreciate you spending this morning with us. Thank you for everyone watching. Please make sure you claim your CME credits by completing the post-test and the evaluation form at the link on the screen. Thank you, everyone. Have a fantastic rest of the day.